Good morning. My name is E.Czerwinski. I am retired professor of Jagiellonian University and have been acting as orthopedic surgeon for 53 years and being involved in osteoporosis more than 30 years, also doing clinical trials. I was the PI in almost all medication which are now in the market. Today, I'd like to talk about the Romosozumab in clinical practice. I'd like to discuss just the basics of the bone metabolism and action of osteoporosis therapies, the efficacy and safety of ROMO. I will cite results of frame study, which was ROMO versus placebo and arch ROMO versus alendronate, and some points about cardiovascular risk in the treatment and ROMO everyday practice and summary, of course. So let me start with remind you how the normal bone turnover looks. And in healthy subjects, we started with activation phase, when there is activation of the osteoclast. They resorb the bone and does the resorption phase. After resorption is reversed when turn out osteoblast and produce osteocyte, and after that this is mineralized and we have new bone. And this cycle takes about 3 to 5 months, and we have the same amount of bone on the end as what in the beginning, so we can adapt bone for a new stresses. In osteoporosis, we have activation of osteoclasts, and more osteoclasts and are more active. We have higher bone turnover, so there is much more deeper erosion, and also lesser production of osteoids. So on the very end, we are losing bone. And this process takes just years. If we apply an anti-resorptive therapy like bisphosphonate and osumab, so we will have less osteoclast, also there will be much more smaller erosions, and then osteoblast comes and produce osteoid, and we have a mineralization phase and a new bone. Amount of the new bone is higher than in the osteoporosis. However, not much, and the main issue is that this bone is highly mineralized and the bone turnover is slowed down, so there is a longer time for mineralization. Quite different story we have in modeling. Let's tell you that we have two processes in bone metabolism. One is the remodeling, which got these three phases, and modeling. In modeling, bone formation starts without the primary resorption. So thus we have activation of osteoblast, producing osteoid, and then mineralization. We have a big amount of a new bone, which is produced quicker. As we talk about anti-resorptive, so we have alendronate, 29 years, isaraldronate, ibandronate, zoledronate, and recently the nasumab. The action is different between bisphosphonates and denosumab, but the final effect is more or less the same. However, the direction which are more effective in this, from the alendronate to the denosumab. Recently, maybe 20 years, we have bone-forming medication, and there are two derived from the parathormone, teriparatide or varoparatide, and romosozumab, which is different, but this is the antibody. The scheme of the bone metabolism control, the osteocyte is the most important cell which controls the whole issue, directly controls osteoblast and also osteoclast. Osteocyte is responsible for bone quality. However, there are many ways to control that, and also we have additional factors about which I will talk today. I will stop just with the romosozumab, and romosozumab is the antibody for sclerostin. Sclerostin is the cytokine which is secreted by osteocyte when it's unloaded and inhibits bone osteoblast. So if we put romosozumab with this antibody, this action is switched off and we have osteoblast just produce bone, new bone. So we come to the efficacy, a frame study, an arch study. So frame study means fracture study on postmenopausal women with osteoporosis. Was based on 7,000 more women with osteoporosis, means T-score less than -2 in total hip or neck. 3,500 patients was on romosozumab for a year, and the same amount for placebo. Every patient was given subcutaneous injection of romosozumab once a month, and vitamin D supplementation and calcium. Then it was extended up to 3 years, but after the year, all patient was on the denosumab. Primary endpoint was the incidence of the spinal fractures after 12 and 24 months, and secondary endpoints were the nonvertebral fracture. Of course, there was also measure of the BMT, bone marker BMD, and X-ray morphometry, which was to detect the spinal fractures, and non-vertebral fracture means hip fracture, petrocranial fracture, and other like radius fracture. As we see on bone turnover issue, on the red we have romosozumab, and on the blue placebo. So in the very beginning, have a very high increase of the bone forming P1 and P marker, and then slow down, and after 1 year it comes to the norm. And the reverse process is the bone resorption marker CTX, and we have the lower level of the CTXs in romosozumab than in placebo. We see that after 1 year of treatment, we have 13% increase of lumbar spine BMD as compared to 5.2 in the denosumab and just 5 alendronate. And after 3 years of treatment, we have increase of 18, so it is almost twice the denosumab and 3 times alendronate. And similar findings in total hip after 1 year increase of 6 years, and after 3 years increase of 9.4%. The same as regards the fracture reduction. No one knows how it was somehow no statistical in Latin America, but in the rest of the world, we have statistical decrease of the incidence of the vertebral fractures. It means reduction 68%, clinical and also non-vertebral fractures by 28%. It was safe. We see here the adverse events, almost the same number of almost serious, educated serious cardiovascular events, cardiovascular deaths. Maybe all deaths will be a little bit higher. Hypercalcemia, single cases. One case of atypical femoral fracture and osteonecrosis of the jaw, two cases. The second study is ARCH, in this fracture study, because the inclusion criterion was not only BMD, but also fracture, either the moderate, one moderate or severe, or two or mild fractures. It was possible because there was no placebo, but the comparator was alendronate. In the first year, there was everybody was on Romosozumab or alendronate, and they were given monthly subcutaneous Romosozumab and weekly alendronate, supplementation of calcium and vitamin D. And the primary endpoint was the incidence of spinal fractures in 24 months, and secondary was symptomatic and non-vertebral fractures. Here we see in the green, there are results for alendronate, and there is results of in the spine. We see that in under alendronate, we have higher and quicker increase of BMD. The same relates to total hip. Similar, we are comparing no placebo, but alendronate, and we have a significantly higher decrease of fractures of the clinical fractures, 27%, non-vertebral fractures, and major vertebral, was really very important, almost 40% difference in reduction of the proximal femur fracture, or is crucial for osteoporosis. Let's repeat, this is comparison between group which was on the alendronate versus those who were on Romosozumab, and there was higher reduction of hip fracture in those treated by Romosozumab. We have also wonderful results of the bone biopsy. We have bone formation. We see that there is twice higher bone formation as compared to placebo, and bone resorption is more than twice lower in Romosozumab versus placebo. And here we see the osteocyte, and the osteoblast formation and the new bone, and the same you have here. The same, you have a trabecular thickness, much more higher, trabecular volume, and here we have micro radiographs on the placebo and Romosozumab, and we see a striking difference. In a special mode of measurement of CT method, it was found that we have higher resistance to stresses in a group treated by Romo in comparison to alendronate. So now we go to the cardiovascular events, and alendronate group, let remind you, 3 years of alendronate, and Romosozumab group, 1 year Romosozumab, 2 years of alendronate. So all adverse events are the same. Serious, maybe higher in alendronate, but unfortunately higher risk on the educated serious cardiovascular events, 6.1 alendronate up to 6.45 in the ROMO. Cardiovascular deaths, however, the same. And 4 cases of atypical femoral fractures in alendronate, and just 1 case in ROMO, and for 1 case of osteonecrosis of the jaw in alendronate and in ROMO group. It was this result of the educated serious cardiovascular was quite striking, especially as in the ROMO, the previous one in frame study was, incidence was almost the same. There is discussion going on, and we'll tell you in a minute, but this finding was documented in EMEA agency. So let's say you medicine must not be given in patients who have already had a heart attack or a stroke, and not use patient with hypocalcemia. So ordering the ROMO, you have to take this into consideration. However, many recent publication doesn't confirm that there is really exist. Meta-analysis, 5,000 articles, 41,000 of patients, and you see the risk of cardiovascular event is small in alendronate, raloxifene, ROMO, denosumab, and teriparatide, and the same relates of the cardiovascular mortality. So just citing this paper, that's mean romosozumab did not significantly increase the cardiovascular risk, mortality, or adverse event as compared to placebo or other anti-osteoporotic drug, and romosozumab might be a safe therapy for osteoporotic women. Not every bone forming are the same. Here we have the comparison to teriparatide in the yellow, abaloparatide, ROMO, abaloparatide in green, ROMO in red, and we see that the gain of the lumbar spine density is highest in the ROMO, and the same rate to. Also, when we compare the decrease of refracture risk just after 2 years of the primary fracture, so we see that the decrease of the new fracture is highest in romosozumab, then teriparatide, then denosumab, and our alendronate. Whom to treat romosozumab? There is indication claimed by all societies, mean IOF, BHOF, ASBEMA, AACE. This romosozumab is indicated for patients at a very high risk. What the very high risk mean? First of all, is a patient with a fresh fracture, meaning fracture which happened 1 or 2 years, as we see 54 fractures will turn out in the time of 2 years, all of them. So this is the group of the very high risk, and in this patient, we should prescribe romosozumab. We have some more, of course, criteria. The more precise is the FRAX criterion. It means that the very high risk is the level of risk which is above the upper limit threshold. I will skip not discussing what that means. And we have also American Association of Clinical Endocrinologists had established the very high risk is fracture within 12 months, multiple fractures when on treatment, fracture given harmful medication means glucocorticoids, very low T-score, and very high drugs. But telling that bone forming agent could be prescribed to as a first, and it should be as a first, but this qualification is only due to economical reason because Romosozumab is much more higher. In Poland, we have about €4 for alendronate and €300 for Romosozumab. So this it will disappear, this qualification, if the other, and we hope that will be medication, bone forming agent will be cheap, so we'll be the first on the first medication, and then we'll follow with some anti-resorptive. So indication in practice, of course, very high risk due to economic reason. Postmenopausal osteoporosis, very high risk of fracture, normal calcium and normal vitamin level. Store in fridge and take off the fridge for 1 hour before administration. Subcutaneous injection, usually this upper arm. You have auto injectors produced by the supplier. And follow up in 3 months, control calcium, vitamin D. 6 months, perhaps bone densitometry, and then after 12 months, and stop ROMO after 12 months, and order some anti-resorptive drug, denosumab or zoledronate, but remind you, you should have a eGFR high more than 25. Supplementation of vitamin D for prevention exercises. I prefer Nordic walking. So, summary. Romosozumab is an antibody against sclerostin, which is produced by osteocytes when there is lack of loads, and it inhibits the osteoblast activity. Sclerostin stimulates bone formation and reduces bone resorption, what gives us the increase of BMD, 18% in lumbar spine and 8.2% in the femoral neck. Also reduces very significantly and more than alendronate and more than denosumab vertebral fractures and non-clinical fractures. In our study, for this head-to-head study of ROMO to alendronate, it showed a very higher decrease of fracture risk in ROMO. It was for vertebral fracture higher than the alendronate, 37%, non-vertebral 27%, and hip 38%. As a group, cardiovascular events of ROMO alendronate was higher, 6.1 against 6.5. However, this was not difference in the previous study, in the frame study, and this was the reason why EMA guidelines that ROMO should not be prescribed in patients with cardiovascular risk. However, it is not proven in the nowadays presentation. Romosozumab is a drug of choice for patients at a very high risk, and after 12 months have to be switched to anti-resorptive medication like denosumab or zoledronate. I'd like to stress that any bone-forming agent is indicated in patients with a very high risk, teriparatide or abaloparatide. And on the very end, that the use of even the most current therapies does not diminish the importance of exercises and for prevention to reduce the risk of fracture in osteoporosis. This is the only way to have the full possible success. Thank you very much for listening, and I hope you enjoyed that. Thank you very much.